Thank you very much. Hello and welcome, everyone. My name is Suzanne Fields. I am with the University of Maryland, the Institute for Innovation and Implementation, and pleased to be your moderator for today's webinar focusing on pediatric care integration best practices. We're going to be talking specifically about screening and behavioral health consultative models during today's webinar. Our webinar is hosted through funding through the National Technical Assistance Network for Children's Behavioral Health, which is funding through SAMHSA, the Substance Abuse and Mental Health Services Administration. This is the second in a 5-part series focusing on various care integration practices. Our series was informed from an expert panel and a report that you can find on our website focusing on care integration opportunities in primary care. In addition to myself as your moderator for today, I'm pleased that we have 2 presenters. The first is Laura Conrad Labyrinto. She is with Mass Health, which is Massachusetts Medicaid, the Office of Behavioral Health. There she serves as the program manager, overseeing all of the services related to the EPSDT Rosie D. lawsuit. There in Massachusetts, those services in that initiative are referred to as the Children's Behavioral Health Initiative, or CDHI is short. In addition to her years of experience within Massachusetts Medicaid, Laura has also worked within Massachusetts Child Welfare in various roles supporting the needs of children, youth, young adults, and their families. Also pleased to welcome Dr. John Strauss. He is the founding director for the Massachusetts Child Psychiatry Access Program and is currently the president of the National Network for Child Psychiatry Access Programs. Dr. Strauss was responsible for the expansion of MCPAP to include MCPAP for moms to address perinatal depression, mental illness, and substance use. MCPAP is the model for implementation of access programs in 37 other states, as well as for the federal legislation in the 21st Century Cures Act, which led to HRSA funds, so Health Resources and Services Administration funding for psychiatric access consultation programs. Through his presidency at the National Network of Child Psychiatry Access Programs, he provides support and implementation to states and localities seeking to implement such technical support within their jurisdictions. In addition, Dr. Strauss has a primary care practice and has been a primary care clinician for over 22 years. Our learning objectives for today is understanding the opportunity to enhance primary care clinicians' ability to identify and link children, youth, and young adults with behavioral health conditions to any necessary services. We'll understand how one particular state, Massachusetts, focused on training and technical assistance to primary care clinicians to better serve its Medicaid population. And then we'll highlight several state examples of various approaches across the country to leverage psychiatric expertise to support primary care clinicians. Our focus today in this webinar, as I mentioned, we have a 5-part series. This particular care integration continuum comes from that expert convening that I mentioned, in which we looked at what are the different opportunities that we have to promote and enhance care integration for children, youth, young adults with behavioral health needs. And so today, again, we'll be talking about, in that first kind of column, those screening opportunities to identify children at that may have needs, but also those opportunities to promote social and emotional well-being. And then that second column, really focusing on those consultative models. And again, future webinars will move us through this continuum that the expert panel created and focusing on other aspects of this continuum. I'll begin by setting the stage and offering up some content from a national perspective about the needs for screening and consultative models. Then we'll have an opportunity to hear from Ms. Laura Conrad Labyrinto and Dr. John Strauss about both Massachusetts experiences and what's happening nationally related to psychiatric access programs in other states. And finally, at the end, we'll have time for Q&A and discussion through the chat box and potentially opening up the phone lines as well. Those of us on this call know this. We probably quote this data in our own work, refer to this type of data often, but we know that there are a high percentage of children who have some type of mental health, some type of behavioral health need at any point in time. And we know that there's those range of needs that exist in this population, from children who have the most complex needs, such as those who may meet kind of federal criteria for serious emotional disturbance, to those who may have more mild or transient intermittent conditions in which screening, early intervention, or treatment may be helpful. From data we know, and certainly we understand, that the primary care clinician does tend to be, for most children, that a longer-term relationship where any type of medical condition can be identified and treated. And we know that in primary care settings, because of that relationship that children and certainly their families may have with a primary care clinician, that upwards of 75% of children with diagnosed mental health conditions are seen in primary care settings. So we know from this that primary care is playing an important role in supporting children with behavioral health conditions. We also know that families are comfortable with that relationship. There is not necessarily the stigma associated with talking to your primary care clinician about your children's needs that there can often be associated with seeking specialty care. And that we have found through data can be particularly true for those from varying racial or ethnic groups who also have the need for behavioral health identification, treatment, and support. And finally, we're all aware of the workforce challenges we have around hiring, recruiting, retaining behavioral health workforce. Necessarily, we're seeing lower numbers of people entering into the behavioral health workforce, and that shortage is impacting the ability to treat and maintain access to needed services. And so primary care can continue to play an even greater or more pivotal role because of some of those issues. As we think about specialty care, so the role of psychiatry, we also know that those behavioral health shortages in workforce are particularly true for psychiatrists that would be trained to serve children and adolescents. Data from a recent survey of the U.S. Workforce population showed just under 10,000 child and adolescent psychiatrists in active practice. And so that then led to a national average of somewhere about 195. And as we begin to think about the population of children that we have nationally that may benefit from those 10,000 available workforce, we know that the national average is about 15 child or adolescent psychiatrists available per every 100,000 children or youth. So we're seeing that kind of shortage of psychiatrists and kind of that challenge in the capacity for those specialists to be as widely available across the country. And certainly this particular data here on this slide, but is available in the report, certainly doesn't highlight that in many states and many localities, there are no child and adolescent psychiatrists available. So some communities experience even greater shortages than others. Ascertaining accurate data about behavioral health screening, the incidence of use of behavioral health screening nationally can be difficult across payers. We are talking about data when there is a potential concern that a child is at risk. We know that it is essential to be able to screen for children and identify as early as possible in order to treat as quickly as possible. And despite efforts to increase screening rates, which in some states can be very low at 1 or 2% and other states much higher, but we know that we would still like the screening rates to be even higher than we're seeing them nationally now. And thus it seems like an opportunity for us to be focusing on one state's experience with increasing screening rates, and then to be talking about that national perspective on how we can increase consultative programs to support primary care. With that, I would like to take the opportunity to introduce Laura. Laura, very excited that you're here with us today to talk about what you've achieved in Massachusetts, how you did it, and kind of what your lessons learned are. So Laura, welcome.
Thank you, Suzanne. Hi, my name is Laura Conrad from Massachusetts Medicaid. We call it Mass Health here. So I'll just start a little bit about the catalyst of kind of how we got to requiring behavioral health screening within primary care. And we did, I just want to preference, we did have a catalyst that pushed our state to mandate the screening due to a federal lawsuit. Some of you, it may have been heard, the Rosie D. lawsuit, which basically said that we were out of compliance with the Federal Medicaid Act of EPSDT. And due to that, and in that federal lawsuit, we were court ordered to improve screening for children that were under the age of 21, that were Medicaid eligible children. So in 2007, we also were court ordered to implement the remedial CBHI, the Children's Behavioral Health Services, and then in December of 2007, we actually began paying for behavioral health screenings within our primary care. So we had approximately about 6 months to kind of get this off the ground and running, and there was a lot of steps that went into place to doing that. Next slide. You know, the first thing we had to think about is the pre-work that we did with all of our health plans. So I will say in the state of Massachusetts, we are a heavy managed care state. And so we had to work with our managed care plans to think about all the things that need to be done to actually roll out behavioral health screenings. So some of the things that need to be think about is just around member services and customer service. We implemented, we created standard training aids across our customer service. We had handbooks and booklets that were standard. We also created materials to describe the behavioral health screen. And one of the big things we did was created member notices that go out to this day still to a member, to every child that's under the age of 20 at enrollment and annually thereafter to describe what a behavioral health is and what should be expected when a parent is taking a youth or the youth is going to a well child visit, what is expected at that well child visit. And so those notices are standard that are issued actually from us to all members. So one of the other things we really had to think about too was working with providers, because the primary care providers and pediatric providers are pretty wide and there's quite a few of them. So we did create standard kind of educational tools around kind of EPSDT and screening. I've listed one of those documents there. It really walks through, it's older, but it's still very valid for people to look at. It walks through what practices you need to think about when implementing behavioral health screening, down to who's going to be the champion within the primary care practice. And also it describes all the tools, the behavioral health screening tools that are approved within the state of Massachusetts. We also had to require our managed care plans to update all of their member handbooks. There's information in every single handbook about a behavioral health screen. And we also, when we rolled this out back in 2007, we did large provider trainings across the state for primary care practices to really talk about what the screens are, how to use the screens, how to score the screens, and then also, in addition, if a child shows up with a positive screen, where then to refer the child for additional services. One of the other things we did in the trainings, too, was really talk about billing because we did have, even though we are a very heavy managed care state, we had standard billing codes and practices that we implemented so we could actually track the screening rates within the state. So just a little bit about the screens. So we do require primary care providers to use a behavioral health screen, and we also require them to use a screen that has been approved by Mass Health, the state of Massachusetts. We developed a work group to actually look at the tools, and we only accepted tools that had efficacy and research behind them to show they were an important behavioral health tool. We still use that work group 10 years later to approve new screens. We approximately have about 12 or 13 screens that we've approved for primary care providers to use statewide. We also had to update our Mass Health regulations. That's just, a small thing. And we also really need to think about, and which I talked about earlier, is the billing and the claiming process, because we wanted it to be standard across all of our managed care health plans and within Mass Health, so we could actually track the screening rates. One of the other things we did is, for people to really, we wanted to push people to start using the screen, because that's great. We can regulate a screen. We can tell people you're mandated to do it. But we worked with our health plans to develop and implement kind of a quality improvement initiative so that they then could work with their primary care practices around how they implement those. And so on the next page, on the next slide, these are a couple of the different screening quality initiative goals that we use with our managed care plans, and held the managed care plans accountable for this. But some of the screenings, some of the measurements were, one is, in the initial, we did this for the initial few years, is what was the rate of screens that were coming in from an individual plan, and so we could track that, and then also what is the rate of follow-up. And so we incentivized our plans and paid them some different improvement dollars around their work around some of this. I'm not going to go through all of this, but you get a general idea of kind of what some of those initiatives are that we did with our health plans. On the next slide, you'll see kind of over a 7-year period where we are today with our screenings. And so I just want to walk through this because some of the data can be a little confusing. So we allow behavioral health screens to take place at any visit that happens at a primary care visit. So if a child actually went in for a sick visit and there was a need to do a behavioral health screen, we would allow that to occur. So you'll see total where we are today, we've done about 2.6 million screens, which is approximately about 70% of all well child visits have had a screen. What that almost 1, 2, 3, the fifth column where you see the screens with visits. So that is basically that the first one for the 0 to 6 month old, that 97.336% is saying that of the behavioral health screens that were done, the 97% happened during a well child visit. But so you do see there are, up to about 5% of screens that happen outside of a well child visit. So whether that's a sick visit, some of the primary cares are doing medication visits. It can happen outside of that. We also allow for, we only allow for one screen to be billed a day, but practices are more than able to do multiple screens a day if they wanted to, but they can only bill for one. But we do allow for as many screens as needed to be billed throughout a year, if you will. So if let's say approximately, if Johnny went in today, for a well child visit, and he had MCHAT for an autism screen done, fine. But then he went back tomorrow and had a PEDS screen done. We would allow the PEDS screen to be done the following day. We don't limit the number of screens within a year. Next slide. Next slide is just kind of some of the challenges and lessons learned we've over the past 12 years. So what you'll see, what you saw on the screening data, we do and still continue to have challenges with, kind of young children and older adolescents, that 18 to 20-year-old and that 0 to 6-month-year-old, and getting primary care folks to screen. And I also say one of the other challenges is around thinking about what screens you actually accept within your state or find acceptable. Is we made sure when we approved screens, we actually added screens that were free of cost, because some of the screens do cost primary care practices money. So it's something to think about. The other challenge we have is, to think about when you're coding and your screens and your claims is what happens after the screens. Do you have some kind of modifier to signify that there was follow-up that was done? Do you pull other claims? It's been a challenge for us to think about, to find that data of what actually happened after a positive screen. And then also, you can see, too, is we have no way actually to know what tool was actually used. So we can't see of the 12 or 13 tools what is the most, the number one tool that's used. We did do a clinical review in 2013, which required pulling records to actually see what tool was used within a record, and that link is listed on the slide, so you could review that. But it is a challenge for us because we really don't have an idea of the different tools that are being used. One of the other things, I actually just going back one thing. Is to think about the coding, and that's one of the challenges we're running into now for, actually go forward on next steps, is when we implemented this 12 years ago, there was limited CPT codes that were available for us. So at that point, we used the 96110, and so that is a challenge for us. In the next 2 years, we are moving away from that code and moving to the 96127 code, which is more of a code that is a CPT code that is designed for behavioral health screenings, and the 96110 is more of a developmental screen, but at the time, there was nothing else that existed. I will say kind of, some of our milestones, too, is almost all commercial health plans in the state actually pay for behavioral health screening, so it's made it easier for practices to implement this operationally, as when a family or a youth walks in the door, the screen, depending on the age, is given to every single child family that walks in the door of a practice. In addition, in 2017, we implemented or added to our list of screens with a postpartum depression screen. I know that's been of interest. We allow for a postpartum screen to happen on an infant or their parent up to the age of 6 months old. We added the Edinburgh to our list of approved screens in 2017. So on the next slide, you'll see our list of screens that we have approved. We annually review this list of screens to either add new screens, or if there's a screen that's outdated or no longer relevant or found to be effective, we can remove screens. We haven't removed any screens. We have updated. You'll see the MCHATs on there twice. It's because we added MCHAT revision a few years ago. But these screens are available. We have a link to our website where you can see the screens that we have approved for primary care or for practitioners to be able to use. I know I went through that fairly quickly. I will say it, too, is, not only did we work with our managed care to pull this out, and I think John will talk about this, is we do have MCPAP, the Massachusetts Child Psychiatry Access Program here within the state, and they have been a key factor, player for us around implementing, when we implemented this 12 years ago, about working with practices also to help practice think about operationally how do they implement a screen. So it wasn't just that our health plans we're out there on the ground working with practices, we actually look to MCPAP also to help us work with practices about kind of what are the best screens, how are we going to implement it, who are the champions within the practice, and again, operationally, how practices do this across. And it varies, I will say it varies dramatically across the state from, practices hand the screen to a parent when they walk in the door to the actually screen is done with the primary care doc or a nurse in a room. So how practices operationalized varies. So I will stop there. It's a lot of information that I've kind of said in a very brief amount of time, and I don't know if there's questions at this point.
Laura, just when you mentioned that MCPAP helped, we actually hired
Thank you, Laura.
Yes, sorry.
We hired 4 screening tool consultants who went out to practices and helped them implement. So we actually had some experts who were out in the field visiting practices, doing webinars and conferences to get folks on board.
Yeah, and I will say it's something
John,
our average screening rate, Suzanne, is in folks is around 70%. It is something still today that we work with our health plans and our practices to continually push them around screening. It is definitely something that you can't kind of let your foot up off. There is definitely things that have been operationalized and standardized, but it's something we still pay attention to and kind of push on practices at different points of time. And especially when we add a new screen, a few years ago when we added, or we probably added the MCHAP for autism screening about 2 or 3 years afterwards, and we also added the CRAFT, the substance abuse screen, about 2 or 3 years afterwards, especially when we add some specialized screens. We do a lot of education and outreach around that.
Well, this is Suzanne. That's very helpful. And John, you were just going to one of the questions I wanted to ask. Before I do, I just want to remind participants to please submit your questions through that chat box function, because we do have time now and then again towards the end to take specific questions you had. But we also did receive some questions in advance, and John and Laura, you're both talking about, I think, one of the key questions that folks did share with us, which was, what does it take to support primary care providers to really be able to do this? And I know, Laura, you were highlighting, basically in 15 minutes, 10 years worth of work you were trying to synthesize for us. And so we all recognize you didn't start where you're talking about now. Can you go back a little bit and talk about how you started out, kind of what you did to support primary care clinicians? And I know, John, you happened to be involved with that at that time as well. And just give us a picture from the perspective of a state or a locality who might be thinking about beginning these kind of efforts, kind of what you did or what you would recommend to folks that are really essential at a starting point.
So I'll say a little bit, and then John can add in. Is I think we are a heavily managed care state, but one thing that was really important to us is we issued standard material guidance that was the same across all health plans, so that a primary care practice didn't feel pushed from different plans to do different things. It was really important that the communication be standardized. And that the trainings be standardized across all plans to all practices. So that's one of the key pieces, I think, for us that we worked on and continue to work on. And we used, again, MCPAP a lot. We hired, like John said, there were hired consultants that did these large trainings and then did individual trainings to individual primary care to help to support the implementation of the screen.
Suzanne, I might add that if we think a little bit about the timing, as I'll talk about a little bit more, MCPAP started in 2004 and 5, and the screening was 2007. Well, that was the regulation, but I think was it 7?
Yeah.
Anyway, the message is that providers don't like to screen for something if they don't know what to do when they get a positive screen. And because MCPAP was available, providers felt more comfortable implementing the screens because if they got a positive and they didn't know what to do, they could call McPath. So I think having these the two are very linked, because most of the practices were relatively at that time uncomfortable with what to do with a lot of behavioral health issues. So having the consultation service available was a key component to making providers more comfortable doing the screening.
And Suzanne, I will add to that too, is when we added the Edinburgh screen in 2017 for postpartum depression, that was one of the concerns that we heard was, what do we do with it when it shows up positive that, the parent, there's postpartum depression, where do we go with this, what resources are available, and actually even down to the details of like, how do we document in our record? It was a lot of questions that we got, and so we, so in Massachusetts we have McPath, but we also have McPath for Moms, which proved, they also did a lot of education and outreach for us, kind of combining those two and really helping practices think about how they implement, the postpartum screen within a pediatric practice, and where do they go for resources and referrals if there's a positive screen.
I'm going back, Laura, to your data slide just for a moment, and I think as we look at this, I think many of our participants on today's call would be quite pleased with the rates that you all are seeing, right? Because they are larger than are occurring in many other places, sometimes where we see, very small percentages, 1 or 2% kind of screening rates occurring. So as you kind of think about where Massachusetts was and where you are now, where do you see yourself going? What are those next set of priorities that you see yourself going to as you look at data such as this?
So I think for us where we are, one of the big things in the next 2 years is we are switching over to the new CPT code, which will at that point, relaunch us to do a lot of education and outreach to our providers. So at that, in the next 2 years, kind of targeting some of the 0 to 6 month old and the 18 to 20-year-olds, in those practices, because some of, the screening, especially in the 18 to 20-year-old, is not happening in a primary care practice. It's happening in a general practice, and so that knowledge can be very different in a general practice that you typically sees adults versus that sees, pediatrics. So it's something that we're thinking about. I think the other piece too, John and I were just talking about earlier is for those some of the specialized screens, especially the CRAFT, which screens for substance use disorder, what is happening with those, who's doing the screen. John and I were just talking about, like, who fills out the screen. Is it the parent or is it the youth, especially when you start talking about the 13, 14, 15-year-old? Is it the parent that's filling out that screen? Is it the child? Because there may be some different responses on that. And we are also working, we in the last year and a half have moved to ACOs. So, we're working with our ACOs to continually reinforce the need for screens. They're focused on kind of depression screen, but within that depression screen, and one of those screens is a PHQ-9, it then reinforces the need for BH screen, because a depression screen using the PHQ-9 would help within that measure for ACOs and that requirement, but it also, again, is a requirement of the state to do a BH screen. So that one tool meets the requirement for both of those things.
That's helpful. That's helpful, Laura. Eric just submitted a question. Thank you, Eric, about where information is entered. And I know Eric's question, Eric specifically asked, does Massachusetts allow postpartum screen info to be entered into the baby's charts? And I'm wondering if you can answer Eric's question, but also in the context of where does this information live that you're gathering for any of these screens, whether it has to do with the question Eric is raising about kind of mom's privacy. We've got some HIPAA issues. Laura, could you give us some insights into what you all have learned in Massachusetts?
Sure, I'll answer partial, and it's great that John's here because they've done a lot of work with practices around that. So for any of the screens that are done, whether it's the postpartum screen or it's an MCHAT, those screens and the results from the screens live within the child's record at the primary care practice. It's interesting because we've seen, some more and more, most practices are on electronic health records, but we've seen actually over the past few years the practices actually adding the screen into their electronic health record. So families are actually being sent the screen electronically to fill out before they actually ever come to the visit. And so that's happening more and more. So as to the primary care, to the postpartum depression screen, where that information lives, the screen on the mother or the father, the mother or the father technically, it lives actually in the child's record. And so John can talk a little bit, I think, better than I can talk about kind of the conversations that have happened with practices around that.
Suzanne, or Eric, who asked the question, I think it's more, pediatricians are all the time putting information in the kid's chart about the family, right? You ask whether there's smoking in the house. You ask about drinking, ask about all sorts of things, and you put that in the kid's chart. And so when the provider, when the PCPs are saying, well, it's really on the mother, that's just an excuse because they're uncomfortable, they're not used to doing this. What they're really worried about, and we've had to support them, is that they're going to do the screen and they're going to find mom, let's say mom's suicidal. And they didn't realize it. And what are they going to do? Because it's the mom isn't their patient or the dad. And so we really had to help them realize that they can call crisis services like anybody else. And yes, they shouldn't leave the baby unattended if the mom is very depressed. But they can handle that. But it requires support. And it's not, again, it's something that they haven't been used to, but they've done very well, I think, getting there.
Thank you, Laura and John. I'm aware of time, so I would like us to move forward to John talking about the national network, recognizing, of course, that these issues and these efforts are interconnected. So we will have opportunity to return to some of these issues with both Laura and John here towards the end. But John, I'd like to turn over you to talk about the national network.
Thank you. And thank you, Laura, for your presentation. And so I'm going to be talking both about national stuff, but also using a lot of information around Massachusetts as the model. And so my goals, first, to talk a little bit about why we have Child Psychiatry Access Programs. We call them CPAP. And then discuss the Massachusetts MCPAP as a model. And then go to the national. And then a little bit about future in terms of sustainability and also about postpartum depression. And first, a little bit about why Child Psychiatry Access Programs. And basically, as Suzanne said, we know how prevalent behavioral health issues are in primary care. And primary care folks haven't been used to, in terms of their training, haven't gotten a lot of training around psychiatry. And we want to be able to support pediatric PCPs to do all the following 6 things. And when I say pediatric PCPs, I mean pediatricians, family physicians, nurse practitioners, PAs, anyone who's in the primary practice, including now integrated behavioral health clinicians. And when we think about this, Suzanne said how prevalent behavioral health is, but we only a third of, it's estimated about only a third of the kids with behavioral health issues get treated in the medical system. So we want to change that. And I sort of think about the 80-20 rule, and I draw the parallel to asthma. Most asthma is managed in primary care. There aren't enough pulmonologists to manage everyone with asthma. And probably even more than 80% of asthma is managed in primary care, but a few kids need to go to a pulmonologist because they got very complex or severe or complicating illness. And our goal with these child psychiatry access programs is to get that same kind of balance where the primary care practice feels comfortable managing most mental health and substance use issues that are appropriate in primary care. And so they need to be able to screen and manage youth with common conditions, ADHD, depression, anxiety, substance use. They need to understand how to connect and refer kids into the community behavioral health system for kids with more complex or many kids who need therapy. They need to be able to use the standardized behavioral health screening tools, as Laura has been talking about, and they need increasingly to understand about the collaborative care model and measurement-based care, because that's how they're going to get good outcomes. And in doing collaborative care, and they need to have the availability of consultation when the youth doesn't follow the normal treatment the guidelines that would normally help with most kids, but there are always kids that don't need help beyond that. And then they need to be able to support the integrated behavioral health clinicians that are increasingly present in practices. So when we turn to McPath, how do we work? Well, we're population-based. We're available for all 1.5 million kids in the state. We're available regardless of insurance. We're available to all practices that see youth. We're funded by the legislature through the Department of Mental Health. And our goal is that you see the mild to moderate, so the scarce child psychiatrist, as Susan says, there are not very few, and Massachusetts probably has more than any other state, does have more than any other state, but still not enough. So we want the scarce child psychiatrist to see the kids with more complex issues. We do this through 3 teams across 7 academic institutions, which are here on your slide. And so that each team has 2 FTEs of child psychiatry, an FTE of behavioral health clinician, FTE of resource and referral specialist, and FTE that's program coordinator. And we have a central administration with myself as a pediatrician, Barry Savet is a child psychiatrist, our medical director, a manager, a program management specialist, and a informatics person. So back in 2004 when we began, that's 15 years ago now, we needed to enroll all the practices across the state. It took us about 3 years to do this. And we had a specific enrollment process to provide orientation, lay out mutual expectations, ensure that the PCPs understood our program and how it works. And that also allowed us to become familiar with the practice and the providers, and to get to know the member, for them to get to know us. It's really a relationship building process so that they feel comfortable working with us to do something that they had traditionally not been comfortable doing. We discussed screening tools, and now to emphasize that the WIC is available now. That's for young kids under 5. That includes the Edinburgh or postpartum screening. And there's now a new screening tool that is so simple that it's not reimbursed, but it's actually nice to do along with whatever you're using for a behavioral health screening tool for the teens, called the S2BI. And it's 3 simple questions, and it's now what we recommend folks use for teen substance use. And then collecting, we also need to collect demographic data for reporting purposes. What are the services we offer? We offer primarily telephone consultation over the phone. We can do face-to-face assessments. We'll talk a little bit more about that. We offer resources and referral information for folks who need therapy and other community resources, and training education. Now, I'll go through these a little bit more detail. So anyone in the primary care practice, whether PCP or behavioral health clinician, can call us and talk. They'll be triaged to either talk to the psychiatrist or the behavioral health clinician, depending what the problem is. And we make the commitment to be able to return a call within 30 minutes. So they can get an answer of what to do while the family is still in the office. I noticed on this slide we say page. That's really, dates us, we don't page anymore, we text. Everybody is on their iPhone, their smartphones and gets text. When the PCP calls, we can most of the time just answer their question. Sometimes we will recommend a face-to-face appointment. I'll talk about that in a minute. And they may need help with resources in the community. For a face-to-face assessment, we thought most of the time when we started, we thought, well, we will need to help them figure out what's going on. Most of our consult face-to-face assessments, which are about 20% of our calls, results in a face-to-face assessment. It's not for diagnosis or medication. It's usually to reassure the PCP. We pretty much on the phone can figure out what needs to be done, but sometimes the PCP or even the family need reassurance, and that one visit really helps. And then we can say to the PCP, now you really can manage this. We're increasingly doing second opinions, particularly for the more complex kids where families are frustrated with the progress their kids make and thinks it's because the person doing the care isn't doing what they need to do. And often it's our job to help reassure them that this is just a slow process, and kids don't, unfortunately, complex kids don't get better overnight. And they well have worsening disease, which is another issue with kids. And then finally, bridging, which is our way of saying, the reality is that there are some kids the PCP is handling, particularly kids, oftentimes kids coming out of hospital, out of a psychiatric hospital, where they can't get into psychiatry. They need a child psychiatrist, but they can't get there quickly for several months. So we'll do a visit and reassure the PCP that they can start an antipsychotic or whatever it may be, and before they get into the psychiatrist. We have, for resource referral, we have a statewide database that keeps track of resources and what is covered in terms of insurance. And that's not a public resource. It's very useful because we can annotate it with the true availability that some providers have, and also with feedback around access and quality and family reviews. We hear that families are not happy with services. Just a mention of resource referral versus care coordination. When a primary care provider makes a behavioral referral, they really need to do care coordination, which means they need to follow up with the family, make sure that they accomplish the referral. When we were doing that centrally, we would call the family up and give them a resource. Only 50% of those referrals made it. And there are lots of reasons for that. The person doing it centrally in our office didn't know didn't know the family, so really couldn't hear the family voice very well. And families are often an initial referral from a PCP ambivalent about that referral. And the PCP knows the family, knows how to work with the family to accomplish to make them realize that this is something that needs to be done. Cultural competency. One person at the McPap team couldn't be culturally competent in all the different cultures that are out in the community, whereas the local practice often has that competency. Tracking, you need multiple contacts with the family before a referral sometimes is completed, and problem solving with, again, that relationship with the family, that there's no ideal appointment. Often there is no ideal appointment time, and help with transportation. Training and education, we'll do anything and everything, webinars, video conferences, newsletters. We talked about the help with screening, and we have toolkits. Brown bag lunches, we'll go after practices. We talk about resources in the mental health system, which for most PCPs is pretty complicated and confusing. We have clinical guidelines and clinical referrals based on those. We help with practices of transforming into more integrated practices. We'll do case rounds. We have some learning collaboratives, and we have monthly webinars. So as I say, you're welcome to go on McPath.org to see our website and our newsletters, and our clinical conversations are all on that website. Like with any behavioral health issue, engagement is key. So we're not engaging with the family. We're not trying to get the family engaged. We're trying to engage with the PCP to then work with the family. And so we want to be helpful in every call. No question is too dumb. We're mentoring. We're coaching. We're personalizing our advice to that person who knows us, and we're dealing with local resources, and we can help in any situation, so we are available for resource and referral. We tailor education to where the PCP is at as they progress in their competency to manage behavioral health. And it's amazing what's happened over 15 years. We're getting calls about things we never would have dreamed PCP would have taken care of 15 years ago. And then we're very careful not to require any system any forms to fill out or any system-required tasks. So in terms of some results, we've now enrolled over 95% of the practices in the states, probably 98%, and the few that aren't generally have some resource that is available to them. If you look back in fiscal year 16, we looked at by our consults by specialty, and if you took all primary care pediatricians in the state, 63% of them had used us at least once. So it's very high penetration. We were just, as Laura discussed, I use this number, 80% of well child visits between 6 months and 18 get the standardized screen. It was there for a little bit. It's come down a little bit. We might want to talk about that as we go, but it's still very high, as Suzanne said. We serve about 6,000 children a year. We do 7,500, 7,600 phone consults, 2,100 visits, and we arrange 3,400 on average per year referrals. And again, to deal with the shortage of child psychiatry, 68% of the time, the medical care, that's if you need prescriptions, in fact, over 50% of the time our calls don't result in any medication. So the care stays with the PCP and no child psychiatry is needed. Therapy is often needed, but not child psychiatry. And we're very cost effective at $2.33 per child per year. PCPs now report comfort with ADHD, depression, anxiety. We're not doing very well with SUD. We're trying to increase that. And this year we're going to try a specific group of SUD experts to be available for consultation and see if that will help. It's particularly a problem because of the increasing use of marijuana amongst folks, and those folks don't really fit into going to a formal SUD program. So what can the PCP do? All right, so now I'm going to go on to the national. It's really an idea over 15 years that's caught on. As Suzanne mentioned, 37 states, and 38 if you count British Columbia. And we think about a third of all the kids right now have their primary care provider can pick up the phone and get a child psychiatrist on the phone. And if you look at this slide, the green states are the states that have HRSA grants, and of the yellow ones are the ones that are new, so there are 8 new ones. And 3 states in red are developing, and we're very pleased that Texas just has money. The legislatures unanimously passed money for a program that will be the biggest in the country, and it's going to do all of Texas, and that's very exciting. If those of you who are on the call, if any of you are in any, I'm sure some of you are in these states. If you have any questions about getting in touch with any of these folks, I can help you. Massachusetts is not the only way to do things. So different programs have come up with different ways of doing a few different things. Not everyone has all the 4 components that we have, so that clearly helps when you can. Some programs include a standard didactic component at enrollment. Some folks have a more organized learning collaborative, particularly a Project ECHO, or a REACH Institute has a learning collaborative program that many states use. Some states promote more standard algorithms. We didn't do that initially, but we are doing that now, and they're available on our website as well as on the Washington website. There are, for more rural states, Michigan has a wonderful program where they have regional behavioral health clinicians in key spots to the state because there are no child psychiatrists in some of the remote areas, and those folks become the eyes and ears for the psychiatry consultant who's back at, in that case, in Michigan at Ann Arbor. Some programs do have pre-consult forms to complete. Some folks rotate child psychiatrists between groups of practices, and then some states are adding psychotropic medication review. Those generally not with the PCPs, more with the child psychiatrist, but it's a way to get funding, increased funding to help support the program and do stuff as well.
John, before you move forward from the slide, can you talk a little bit more about what you mean here about standard algorithms? So you mentioned Washington has started doing that. Other states are considering that. Can you add some clarification to their use here?
So that would be for the common disorders, ADHD, depression, anxiety, having a flow sheet and a set of procedures for the PCP to follow when that's an issue. And we've done ones that are on our website, Washington. I'm not exactly sure which ones they have at the moment, so they definitely have those 3. We're going to be adding, in addition to those, PTSD, OCD, and autism. So it's just a way of helping the PCPs have a structured way to approach them.
Thank you. That's a helpful clarification. Just wanted to make sure listeners fully understood that bullet. So thank you, John.
Okay, now going forward, sustainability is a huge question. The HRSA grants are wonderful, but they're only seed money. They're not going to, in most states. So they're 5 years. We don't know what will happen after that. But in most states, they won't be enough to do the whole state. So, and also postpartum depression and McPap Vermont. So let me start with sustainability. We now feel in Massachusetts that we're sustainable. The budget is set annually by the legislature as part of the Department of Mental Health Appropriation. And in fact, it's now included in the governor's budget so that it's really become standardized. And the commercial insurers pay their share proportional to their utilization of the program. And that's now a state law. So it does need to be lobbied every year, which we used to have to do. But it happens automatically. Each commercial insurer pays their share of the commercial share of the cost of the program using a formula that in our state happens to be was developed because in Massachusetts with the Department of Public Health centrally purchases childhood vaccines. And they have a formula that makes no sense but works. So I won't go into the details, but there's many ways you could do it simply by the number of kids in the program, in the plan. But, and then for the Medicaid portion of the cost of the program, Medicaid agency pays that and obviously gets its federal match for that. So the state ends up paying very little to run this program right now. There are other funding mechanisms across the country. I'd like to point out the Pennsylvania model where they're a fully managed care state so that they've added the cost of the program to their to the capitation, to the physical health plan in proportion to the child population. And then the managed care plans have come to 8 of them have come together as a consortium to contract with 3 vendors to deliver the service. Health plans could agree to split up the cost voluntarily. That's never happened, but it's theoretically possible. And then you can continue to rely on state funding and even grant funding, but that's that's risky going forward. So we really think that this should be a service that is needed by all members of the community and should be paid for out of the health insurance dollar. A little bit about McNabb for moms and postpartum depression. We sort of started, one reason we started, as Laura mentioned, was because pediatricians wanted to be able to screen and needed help with when a screen was positive. But because it occurs in 1 in 7 women, it's the most prevalent ACE, adverse childhood event, and it needs to be available to dads and adoptive parents because it's as prevalent there as it is with women. And you can get lots of information on the website, McNabbformoms.org. But what I didn't know as a pediatrician and was really helped as we were thinking about this by Nancy Byatt, who's a perinatal psychiatrist at the University of Massachusetts Medical School, is that 60% of women who develop postpartum depression are identifiable before delivery. About a third have a history before becoming pregnant of a mood disorder or other mental illness. A third will screen positive during pregnancy, and then a third clearly develop the problem postpartum. So with this information, it became clear that if you could identify and treat this issue before delivery, the child would be much better off because the mom wouldn't be depressed. And so the goal was to teach all obstetric providers to screen and manage perinatal depression. And we've been able to do this over the last 5 years, which has really been very rewarding. We have a team of one FTE of perinatal psychiatrists across the state, and 2 resource and referral specialists, and a part-time medical director. Our goal is that all 72,000 women who deliver in the state will have a screen initially, their initial prenatal visit at 6 months, and their postpartum visit. And the pediatricians will screen at 1, 2, 4, and 6 months well-child visits. And I say the SWIC is the preferred instrument to do that. And increasingly, we're dealing with SUD issues as well. So we've trained 74% of the OB practices, covering 82% of the deliveries, and we've served over 6,000 women and done almost 4,000 telephone encounters. We need to see about half as many of the folks we do telephone consults on, 10%. We do a lot of care coordination, and in this case, it is actually care coordination because they seem to be folks seem to be pretty motivated, so they're following through with when we call and talk to the families. And interesting enough, even though 72% of our consults are with OB practices. 14% are with psychiatrists who often have who may have a patient who's been on chronic medication and become pregnant, and they're not sure what the risks and benefits are, and they call us. And 14% with any other provider, 5% of which are pediatricians. So that's my presentation. I have a few references, and whoops, I guess the last slide didn't. I'm not sure whether my contact information, I think, was a slide on there, but anyone's welcome to contact me if you have questions or going forward.
Thank you, John, very much. And I would encourage folks to please submit questions through the chat box. And in a moment, I have a slide that will show with information on how to contact all three of us for additional information. So, John, it's there combined for everybody when they download it. Welcome your questions now. John, I did want to start with one we had already received, which is, and again, this kind of parallels the question I had asked to Laura. MCPAP has been in place for many years. MOM has been in place for 5 years. Other states are in various stages. Where would you encourage people to start? What would be the top 3 to 5 things that somebody in a starting place within their state or locality should consider?
Well, I think the start is a political process. Before we started, there was a formation of a group they call themselves the Child Mental Health Task Force, and it was a multi-stakeholder group that worked with the governmental agencies as well as providers and PCPs to develop the political will to put this in the state budget. And I think that's the key process, because it's getting funding. You can start with some grant funding, but even that is good if you've got a political group of stakeholders working on that. So that's really the most important thing. And that group has continued over time. It's also splintered into a child mental health campaign, a more specific group that lobbies for things much broader than the PCP world would need, lobbies for mental health care for kids in general. So it's that process is what really drives this. And most of the states who have been successful before the HRSA grants were able to do this. And even with the HRSA grants, if they want to be sustainable, they have to worry about how to get stakeholder support.
That's very helpful. Thank you, John. I have another question for you, which is about billing codes, what the specific CPT billing codes that are being used. This question is specific to MCPAP, but if you're aware of how other states are approaching it, that information would be helpful also.
That's a good question. So there are now, CMS has approved some billing codes for consultation. They're sort of limited. They were designed to work with the in the collaborative care model where you're consulting to someone in a practice. You can't, these programs can't survive on just billing a individual call. I mean, this is a more firehouse model where you're available within 30 minutes, and to keep that kind of availability, you need more funding than just what would come out of using billing codes. So I'm not aware. Minnesota actually, initially, their legislature passed billing codes a long time ago, and they tried to get a program up and running with just using those, and they couldn't do it. It just isn't, I mean, unless you make the charge per call ridiculous, and then no one's going to pay, CMS will not like that. So you need some core funding.
Very good. So that sounds like that funding for a firehouse model, the capacity always needs to be available. You don't know when calls are going to come in, but then some use of some kind of specific CPT code. So it sounds like a bit of a bundling approach where it's been most fruitful or sustainable. Understood.
There's another problem with CPT codes. The CPT codes that were developed for use with the collaborative care model is where the consultant has a real relationship with the practice, and there's probably medical leaders on the hook, as it were. One of the keys to these programs is that it's basically what used to be called a curbside consult. You don't have a doctor-patient relationship because you're not talking to the patient or the family, and you're talking to the provider. And at this point in time, that's pretty risk-free. As far as we know, there hasn't been a successful suit around doing this kind of work. And if you start doing billing, you probably I wouldn't think you'd have that same standard, because then you really do have a relationship with the patient because you're billing the patient. So it's probably not a very good idea. It's much better to use the firehouse model and keep it strictly a consultation. In fact, we have a medical record system, and we call it a educational advice. We don't, because what we don't want to be doing is saying you should start Prozac tomorrow. We say, given what's going on with what you've told me, this is my advice. And that's very different than being in a supervisory or in a patient treatment setting.
That's helpful. That's helpful. John, we're getting several questions in about CPT codes, and I know that there's some other issues, other questions we have. So rather than trying to answer every CPT code question that we're starting to get, is there a resource available on your website where people can find out how different states are handling this issue? Is that something that might be available at the national network or through MCPAP? I just want to be able to direct people to some more of the detailed questions that are coming in right now about CPT codes.
I think SAMHSA's SAMHSA has the integration website, which is name I should have on the tip of my fingers.
Sure.
It has all that information.
So the Center for Integrative Health Solutions, understood. Right. Okay, and then that potentially then, thank you for that as a reference that we can follow up for people as well. So thank you, John, for that. You did mention about use of texting as part of your intervention, and I know Allison had asked that question, but I wanted to make sure that I also understood it in the context of how you're using texting, documentation issues, privacy issues, et cetera. Could you talk a little bit about that technology and how you're incorporating it and then handling some of those challenges?
Right. So we have a web-based application so that when the PCP calls in, we take the program coordinator answers the phone, takes some basic information, and then and based on which psychiatrist is or behavioral health clinicians on call, they just put that name, they click on the drop down with that name, and it automatically sends a text with all the information for the person to call back the PCP. So rather than in the old days, we would page the doctor and tell them the name of the PCP who wanted to call back and what's a little bit about the problem and the urgency, because sometimes the PCP wants us to call back, at lunchtime, not immediately. We can now do that automatically through texting. So they get on their phone the text that says, call Dr. Smith at such and such a number at 3 o'clock, and wants to know, has a question about medication or something, they'll get a little brief thing. So that's all, that happens. In terms of confidentiality, because we get lots of kids, as most of you know, the problems aren't going to go away. So we're getting lots of calls on kids now over years. So we are taking down, we keep track in most cases. If the doc doesn't want to give us the name or the family hasn't given us, the doc is, PCP is supposed to ask the family, I'm going to call McPath. Is it okay if they have, you know, they're going to have your child's name in case I need to call back, and they'll have that information. So we do take the kid's name. However, if someone for some reason doesn't want to give us that, we can answer the question. We put it in as no name encounter. But the disadvantage there is if they call back, we have no information about what was said before, and they sometimes don't get the same consultant when they call back. So it's useful if we have the child's name. And we now, as I say, we have some kids who've had calls back over 15 years.
That's very good, very good. I'm wondering, and this is a question for John and or Laura, interested in both your perspectives. John is somebody who is a pediatrician and has been working on implementing these programs in other states. And Laura, just with your Medicaid policy hat on, kind of what you see as the future opportunities for consultative models such as this that can support children and families. I'm thinking about this, today's context with how do we identify children that we aren't reaching. And so we know screening is a key way. We know, Laura, your data coming out of Massachusetts is there's a sizable number of children with positive screens that had never been identified in the data before, right? So it was like a new population that the screening is reaching. And we're hearing, John, from you about McPath and other models like this that are intervening early. We also have, folks on the phone who are concerned about that really complex population that may not necessarily be getting everything they need. We've talked a lot about children that may be too young to be getting certain medications. We have primary care clinicians who may be concerned about the dosage, that dosages may be too high or there's too many medications. So we've got those sets of issues as well. Can either of you kind of speak to how consultative programs such as that have helped those issues for kind of populations with more complexity?
Well, I think Bob Hilt, the Washington program, PAL, has some good data because they're doing the psychopharm consult. They have some good data that the state has addressed some of the polypharmacy issues, and it's been very helpful in terms of their because they're part of the state's prior approval of medications, psychotropic medications. So they have some good data that's really changed the state's performance on that. We don't.
That's helpful. That's helpful, John. Thank you.
Suzanne, this is Laura. And thinking about kind of policies and kind of thinking about this consultation model and for states to think about, and there's been some things thrown around in Massachusetts, and not to say we're doing this, but it's been thrown out there, is, some of the challenges that people are seeing is in primary care and just across the system is youth that are identified with an autism spectrum disorder and kind of the resources and referrals for that and where to go with that. And there's some bottlenecking happening with resources and referrals for them. And so, should there be some other kind of consultation model, if you will, for autism? Because it's become such an issue here, such a challenge for primary care and folks to think about how to treat them, where to refer them, how to think about what to think about that. So it's something that's being thought about here. Not to say we're anywhere near moving it, but just thinking about policy and procedures to think about is how do you bring in that kind of autism piece into the conversation.
And I don't want to give the impression that McPath has helped a lot in terms of access to psychiatry and medications when they're needed, but it has not solved the child psychiatry access totally. There are still the complex kids that have a hard time, and families that have a hard time with insurance coverage for psychiatry to get access to medication. So we're designed for the mild to moderate, but one thing I can say is we certainly have seen pediatricians now much more comfortable, as I mentioned before, advocating for their families with complex illness. I think before when they came in for a well child visit, those kids would get their physical exam, but they didn't get much help with their behavioral issues. And now there are a number of pediatricians who are much more comfortable, especially as the ACOs become more accountable for it, to question what's happening, and they now feel that they can call and get some advice. And we certainly complement, as you know, in this state, we have all the CBA, Child Behavioral Health Initiative services from the Rosie D services and from Rosie D Remedy. And we certainly promote the PCP's understanding that and using that. And
John and Laura. Yeah, John and Laura.
Suzanne, you may
please
not
go
be
ahead, John.
As of July 1st, the commercial payers now have to cover for their non-ERISA folks. They have to cover all the CBHI services.
Well, that sounds like an opening for a follow-up webinar. How does that sound as a moderator's wrap up to that? That sounds like a very interesting development and one that would be worthwhile to learn more about. I am aware we are coming to the end of our time today. I want to thank very much Ms. Laura Conrad and Dr. John Strauss for their content and their insights today. We want to thank all of you for joining us for this webinar. As was mentioned at the top, this is a series that we are hosting with a third webinar occurring in October, focusing on aspects of children that have moderate or more intense needs, with 2 additional webinars coming later in the fall. And we have additional information available at our website, as well as the contact information for myself, Laura, and John. So thank you very much for joining us today. And we would ask if you could please take the survey that is available. That survey provides us important information to inform future webinars, as well as follow-up content we can provide on this topic. So John and Laura, thank you so much for joining us today, and to everybody who was on the call, have a good day.